Hai Asdani.
Hai,
Okay ya.
hai Retno.
Apa khabar? Okey kah?
Okey.
Ha. You sudah terima email saya kan?
Dah,
Tentang perubahan jadual. So kena ada sikit perubahan.
okey.
Dan sebab dekat IJN doktor
Not accepting 2 months kan, Dr. Chok?
ya.
I heard.
Dia mau 4 bulan. So that's why you put in there.
Yeah.
Hmm. So after
Dr.
that.
Chok, why I can't share my screen?
Oh yeah, I have not allowed yet. Yeah. Okay. Now okay already. I allow the sharing already.
Okay.
Cuba share tengok boleh. Sudah makan kah?
Minum
Belum.
already.
Sibuk
Makan after this.
Okay. So you're alone, right?
Breakfast already, Dr. Chok.
Oh, okay. No, you're alone, right? You're alone in UMC, right, at the moment?
Yeah.
So you dengan Prof Gan aja kan?
Yeah.
Oh, good. Then can do more.
Dr. Can hear me clearly?
Can. But you cannot hear me, is it? Can you hear me?
A little bit pecah-pecah.
Pecah. Maybe my line. But I can hear you well.
Okay.
Ah. So far coping?
So far, okay.
Tak ada mau apa tu? What do you call that? Tukar fikiran Tidak
Hopefully.
Not going to change your mind. Okay, because 3 months already, right? So July, August, September. So this is your last month that you can tukar fikiran. They give you 3 months, right? This time. They give you 3 months of so-called.
Percubaan, the probation period.
Yeah, they did.
Yeah.
Okay. Busy or not? Which one is busier? Is Kedah busier or which one busier? Kedah or UMC busier?
Kedah.
Kedah busier lah. So that's good.
Yeah.
Then you can have a bit more relaxed.
Not relaxed. So Dr. John here got more complicated liver case that I have not exposure before. So CDH, so I learned a lot here.
Good. Yeah, so that's the purpose of go around that you can see more. Yeah. Good.
I have the first experience of using CBVH.
Very good. And a liver failure patient.
Yeah.
All right. Then after that, you'll be expert when you go back to Alostar. Then you can start using your machine. But Alostar is still Aquarius, right? You still have the Aquarius. Aquarius, right? Your CRT machine is Aquarius, right?
I think we got Prisma Flex also.
Oh, okay, good. So UMC using Prisma Flex, Okay, good. So you adapt yourself really lah. I mean, it's quite a different environment, like as compared to Kedah.
Yes, it's like university. Back to my university life.
All need to be academic
surrounding by all the master students.
Okay. So how many master
learn from
students?
them also.
How many master students with you now in the unit? How many master students with you now in your unit?
4 to 5% per rotation.
Per rotation, right? Okay. So at the moment you have 10 bed, right? Or already opened up more?
10.
10, okay. So hopefully Dr. Justin will come back soon. When is Dr. Justin come back?
No, I think next year, but not sure which month he will come back.
All right, next year. Okay. So by the time you already in IJN already. You're not too far, right? The place you stay to IJN, or you need to shift?
It's about half an hour.
So are you going to move, or are you going to stay at the same place?
Mm.
Are you going to move, or are you going to stay at the same?
I have another choice because my friends now in HKL, they offering me to stay together if the journey quite far or jam.
Oh, yeah.
So
That would be better. That'd be better, isn't it? So that you, after call, you tak payah bawa kereta lagi. Now the place you stay is walking distance, right, to the UMC?
Walking, yes.
Okay, so
About
you know.
700-meter walking distance.
Okay, so you walk or you drive?
Yeah, walk. I walk. I rather walk.
Yeah. Nanti susah mau
It's
cari
very
kapal.
difficult to find parking.
Yeah, true. Yeah.
Hai Hasliani, hai Lilin.
Hi.
Hello.
Hi, Lilin.
Nanti nak minta tahu dulu kat mana.
Yeah?
VPM.
She was asking Hasliani, he want to find out where to stay.
First we'll be there for 2 months or 4 months, so have to see whether they want to sewa ke masa yang pendek.
I can give you recommendation for a few places.
Bagus. We PM
I think for guys a bit easier to find things.
Okay. Because I think better not to drive. Traffic is a problem there. Parking also.
Yeah, parking is the problem.
Thanks.
Okay.
Hi, Myra. Chiong, okay, Chiong?
Hi, Dr. Chong.
Okay.
Successfully.
Okay. So far, so good,
So far, so good. Already running very well.
Well done.
Thank you, Dr. Chong.
Hasliani 每次 goodbye Relax jangan takut. Hari ni you popular, ramai yang datang. Myra. Okay, I think we can start good. Yeah, ramai sudah datang. Yeah.
I start. Good afternoon, everyone. Hasliani here. So today I will be sharing about anatomy and physiology of liver. So we start off with embryology and anatomy, then followed by blood supply of the liver, including the venous drainage and also the innervation of the liver. Subsequently, we go to functions of the liver and some clinical application of liver that we should know of. So from the embryology, the liver is derived from the ventral protrusion of foregut, which is the ventral part derived to pancreas, and the caudal part will develop to gallbladder, and the protrusion will further divided to form a liver. So as we all know, liver is the second largest organ. It's constitute about 2% of our total body weight. So it starts from the third week of gestation and mature at 15 years of age. So our liver is surrounded by a capsule named of Gleason's capsule. It's a name of over a person, which is the pathologist. And also anatomically is divided into right lobe and the left lobe, divided by this falciform ligament, and surgically is divided into a segment. It called a cornet classification, is a name of a surgeon. So the segment divided into the left lobe, which is the segment 2 and segment 3, and then the right lobe, which is segment 4. It anteriorly is got segment 4A and 4B, segment 5, 6, 7, and 8, and the segment 1 is the caudate nucleate located posteriorly. So this is the unit of our liver. It receives dual supply from portal vein and also hepatic artery. So the main proportion of supply is from portal vein is constitute about 75%, and also 25% from hepatic artery. Why is this so? Because the portal vein develop intrauterine, which they give the most supply to the liver, whereas the hepatic artery, it develops later on in intrauterine life and further matured during the post-delivery life. That's why the main proportion of the blood supply to the liver is still the portal vein. So portal vein is carry nutrient-rich, deoxygenated blood, and it's low pressure venous system. And hepatic is a branch of celiac artery, is carry oxygen-rich blood. So liver also has their own hepatic buffer system, which is control the hepatic blood flow. There are certain factors that can cause increase in hepatic blood flow and also decrease in hepatic blood flow. This include factor which is increase the hepatic blood flow, which is mainly caused to vasodilatation, which subsequently increase the flow to the liver. Namely the factor would be hypercapnia, food intake, decomposition, and some liver-induced drugs can cause vasodilatation and increase blood flow to the liver. Decreased factor will be the ventilation, hypocapnia, hypoxia, cirrhosis, and volatile anesthetic drug, and also some vasopressin cause vasoconstriction, leads to reduced blood flow to the liver. And venous drainage is mainly the 3 hepatic vein. It's divided into the segment, which is the left hepatic vein is drained from the segment 2 and 3. So the middle hepatic vein, it drained from segment 4, 5, and 8. Meanwhile, the left hepatic vein is drained from segment 6 and 7. Whereas the segment 1 will drain straightly to IVC. How about the lymphatic drainage? So lymphatic drainage is runs along adjacent to our portal vein, which is the hepatic node, the celiac node, and gastric nodes. And if you can see, is the microscopically arrangement. The lymphatic vessel will runs in this perisinusoidal space near the portal vein. So any disturbance in this balance of lymph drainage will cause ascites, one of the reason of cause of ascites. So we go to the functional unit of liver. It's a hexagonal shape, or we call it as lobule. It contains thousands of hepatocytes units inside. So the arrangement of these lobules is its hepatocyte is arranged in the zone. It divided into zone 1, zone 2, and zone 3. If we can see, the zone 3 is near to the portal vein, whereas the zone 2 is more near to our portal triad. So in zone 1, this is high perfusion because it's near the portal triad. It receives more nutrient-rich blood, and also it involved in more important function of the liver, which is oxidative metabolism. Whereas zone 2 is mixed transition in between zone 2 and zone 3. Whereas the zone 3 is a lowest perfusion area because it's distal from the hepatic, the portal triad. So if any incidence of hypoxemia, the zone 3 will be most affected. Zone 3 will involve in mostly detoxification and biotransformation of drugs. So this is the microscopic of the hepatocyte, how the cells in the hepatocytes was arranged. It contains of endothelial cell, Carpal cell is act as macrophages in the liver system. Stellate cell, which contains of high amounts of lipid and as a storage of lipids. Natural killer and pit cell react as a immune defense to the liver. So we go to the function of the liver. So I divided into metabolism part, detoxification and drugs metabolism, storage and reservoir, synthetic function, immunological and function, and also excretion of bile. So the metabolism mainly the carbohydrate, the lipid, and also the protein metabolism. So as we all know, the carbohydrate metabolism is involved the gluconeogenesis, glycogenolysis, and gluconeogenesis. So glycogen is the main carbohydrate stored in the liver, and it's very sensitive to insulin level and also the glucose level in the blood. So whereas the sense of low sugar, it will stimulate gluconeogenesis and glycogenolysis. So this is the mechanism of glycogenesis. Is the glycogen production, glycogenolysis, which is glucose production, and gluconeogenesis, and is the end products of the can be into glucose and also can be in the glycogenesis. Lipid metabolism is consists of lipogenesis, lipid storage, and also lipid consumption and ketogenesis. So the lipogenesis is a synthesis of lipids and fatty acid. The lipid storage, which is the stores as triglyceride synthesis and formation of lipid droplets, and ketogenesis with end products of ketone body. So this is how the lipid metabolism occur to lipolysis, which is the fatty acid bound to albumin from the plasma enter the liver. And then ketogenesis when the end product is ketone bodies, and also and the process of bile acid production. So protein metabolism will undergo these three process in the liver, which is the transamination, deamination, and lastly the urea formation. The transamination, which is the amino acid converted into keto acids, and with this aminotransferase enzyme, it will produce glutamate. Whereas then undergo this deamination, whereas glutamate is metabolite, and this amine group will be removed and will form ammonia. And subsequently, ammonia will be enter the urea formation. The urea cycle lastly will be excreted in the urine through the kidney. And the other function of the liver would be the detoxification and also drug metabolism. This process is the aim to convert these drugs from the lipophilic content to the hydrophilic content that can be easily eliminated in urine later. So this mechanism will involve three phases: phase 1, phase 2, and phase 3. The phase 1 is called biotransformation. It involves mainly this cytochrome 450 enzyme will undergo this oxidation, sulfur oxidation, and hydroxylation, and will make the drugs more hydrophilic by add on a single oxygen atom in the drugs. So the phase 2 would be conjugation. Conjugation, which is involve all those liver enzyme, and to conjugate with these drugs and to make it more water soluble, and then later to be excreted in urine. The last phase will be excretion, which is readily to be excreted to the urine through the and also excretion by the bile. So important to know that some drugs can increase or induce or inhibit this cytochrome P450 enzyme system. And we know that some drugs can cause liver inducer, and some drugs can inhibit hepatic enzyme. So the some of the drug of liver inducer, namely our AED, phenytoin, carbamazepine, barbiturates, rifampicin, and alcohol, the enzyme that could inhibit the hepatic enzyme would be omeprazole, erythromycin, sodium valproate, isoniazid. So I'll touch a bit about how this three phase can implication in the acetaminophen toxicity. So acetaminophen goes these three phase. Is not only produce the hydrophilic, which is water soluble drugs that will be excreted in urine, but it also produce a harmful metabolites. Okay, so once 90% of acetaminophen will enter phase 1 metabolic pathway, which is the conjugation phase, and then as using this UDP, glycuronyl transferase and sulfotransferase, will convert into this glucuronidated and sulfated metabolites that later, which is the hydrophilic form, which is later eliminated in the body through urine, whereas this remaining 10% will enter phase 1 oxidation by the other cytochrome apart from P450, which will form highly reactive toxic metabolite, which is called this N-acetyl parabenzoquinone or NAPQ1. And this how they eliminate this 10% toxic, which is conjugate with glutathione in the phase 2 and later excreted in the urine. What happened in the acetaminophen overdose, which is excess of this NAPQ1 harmful metabolite formation. So this NAPQ1 will cause cellular protein modified destruction and also causing the cell death. Because this in the phase 2 that I mentioned before, it conjugate with the glutathione. When the excess NAPQ1, this means that all the glutathione has been desaturated with NAPQ1. So the free NAPQ1, that's the problem that caused the protein and also cellular protein and also called cell death. So the antidote for this NAPQ1, so the aim is we want to increase the glutathione as a co-transporter for this NAPQ1. So this N-acetylcysteine works by replenish glutathione stores. So it will bind directly to this harmful metabolite, which is subsequently be excreted in the urine. So any irreversible damage will further lead to liver cirrhosis, and also the end is liver transplant. And the liver as a liver also has a synthetic function, which is produce all these component, which is plasma protein, coagulation cascade, some hormone IGF-1, thrombopoietin, angiotensin, and also some carrier protein, which is the albumin, ceruloplastin, and also apolipoproteins. So storage and reservoir, liver receive 25% of cardiac output via this dual blood supply, which is at one time it can store about 500 ml of blood. So hepatic blood flow would be the 1,200 ml per minute. And each time if the circulating blood volume fall, especially in hemorrhage, the sympathetic stimulation can mobilize this store blood in the liver and bring it to the systemic circulation. But in a prolonged time of bleeding, this reservoir will be used up and also leads to hypovolemic shock also. And the other day also stores for vitamin and iron, and also some serum vitamin B12 raised in certain condition, which is acute or chronic liver cell disease associated with myeloproliferative disorder. So serum B12 raised in the blood because of this cell death and release of vitamin B12 to the circulation. Serum iron and also serum copper also will be raised in liver injury or liver cell death, which is this iron and serum copper will be released in the blood. And liver also act as immunological function, which is through the phagocytosis modalities, which is has its own macrophage system named as a Kaffer cell, which is engulfed is this all by bacteria and viruses from the system, and also initiate of inflammation, whereas this macrophage Kaffer cell react to the and responds to the pro-inflammatory cytokine, and also is produce inflammatory protein synthesis, and which is produce complement proteins and also C-reactive protein, and act as defense mechanism to the liver. And the last function would be bile excretion. So hepatocyte produce bile by conjugated bilirubin and subsequently and drain into the bile system and also excreted in the urine and also the feces. Total bile flow and bile secretion is about 600 ml in each day. So we go to the last part, which is the clinical application related to the liver. So we go to the liver function test or hepatocyte biochemical parameters. So as we all know, the raise in all the liver enzyme transaminases indicates that there was a hepatocyte damage or injury, whereas the increase in the ALP and GGT would indicate that there's a obstruction in the intra or extrahepatic bile duct, and the raise in bilirubin and ammonia indicate that there's a problem with the hepatic clearance. And the synthetic function of the liver, PT is a sensitive indicator for the acute liver injury because this coagulation profile has half-life is about less than 24 hours. Whereas in hypoalbuminemia, it indicates more to the chronic state of liver because the albumin half-life is about 30 days. So we go a little bit about the liver modalities of regeneration of the liver. In the context of liver injury, hepatocyte has this ability to regenerate a new cell completely as long as there is a remaining 25% of normal tissue remains. And this process is initiated through this cytokine growth factor mediated pathway, involve this tumor necrotic factor, interleukin-6 growth factor mediated, and also this hepatocyte growth factor, and also transforming growth factor. And in the case of liver resection in liver transplant, where we remove the part of the liver, so the donor liver can regenerate complete restoration of their liver mass within the 3 months of duration post liver transplant. So what happened in liver failure? Why this hepatocyte cannot regenerate fully if there is a liver failure, liver cirrhosis? Because this chronic liver injury is exposed to the prolonged apoptosis, which subsequently will downregulate the regeneration. This involves release reactive oxygen species they call ROS, which is fibrogenic mediators and subsequently stimulate the fibrogenic action of myofibroblasts and will form fibrosis rather than a new cell. In chronic hepatitis infection, that one of the cause of chronic liver injury, this well to know that they can induce hepatocyte arrest and impact hepatocellular function and also limit the hepatic regeneration through this process of fibrosis. And whereas in chronic cholestatic disease, the toxic effect of the bile salts induce the hepatocellular apoptosis, which cause activation of the hepatic stellate cell into myofibroblasts, and also later on will undergo the fibrosis process and will end up with liver cirrhosis. So when liver cirrhosis happen, it will lead to portal hypertension, because our normal portal vein is a very low pressure, is about 5 to 10 millimeter mercury, and when it exceeds of this pressure, it will cause the portal hypertension. So combination of increase in portal resistance and also flow will lead this signs and symptom of portal hypertension, namely ascites, where is the high venous hydrostatic pressure lead to net fluid filtration into the peritoneal cavity, and the splenomegaly, when it's the impact venous drainage that cause engorged spleen, and in long run will cause splenomegaly and cause hypersplenism, end up with thrombocytopenia, anemia. And also this portocaval anastomosis, high portal venous pressure will produce this collateral vessel, which is later on will dilated and engorge and leading to the esophageal varices split, and also rectal varices and caput medusa because of the engorged vein. And in hepatic encephalopathy is a neuropsychiatric abnormality because of the build-up of ammonia, which is caused direct neurotoxicity, cause astrocyte swelling and dysfunction. And the other thing is a hepatorenal syndrome. It can happen in 30% of occurrence in liver cirrhosis. This is because increase in hepatic injury results in reduction in renal perfusion. So it leads cirrhosis. It leads to portal hypertension, splenic vasodilation, reduce the efference arterial blood pressure, subsequently activate the vasoconstrictor system, leads to renal vasoconstriction and hepatorenal syndrome. And some of liver with anesthetic drugs. Traditionally, this inhalation anesthetic drugs can induce hepatitis, especially halothane, which is seldom be used now, because it's 20% of halothane dose was metabolized in the liver, and with newer generation like this fluorines, isoflurans, and sevoflurans, it's less percent of those metabolite in the liver and less incident of hepatitis. Even this sevoflurans has 3% of those metabolites in the liver, but the end product is less hepatotoxicity compared to this halothane. And in liver failure, the use of morphine will accumulate as extraction ratio reduced by enhancing further the effect of morphine. So usually morphine will be carefully used in liver failure patient. And the popular medication will be used in liver patient, which is just remifentanil, because it has no active metabolites and it's not metabolite in the liver. And interaction with liver and with ventilation. In case of hyperventilation with large tidal volume, decrease the splenic blood flow as well as increase resistance to the hepatic vein and portal flow. And this will lead to reduce oxygen delivery to the liver and can cause hypoxia to the liver. And however, if this happens transiently, it can overcome the duration, and subsequently it will back to its normal hepatic flow and also oxygen delivery. In positive pressure ventilation, decrease in hepatic venous flow because this our PIPs increase in intrathoracic pressure, which subsequently reduce the hepatic venous flow and can cause hypoxia to the liver. I think that's all for my sharing.
Thanks a lot, Haslani. That's a very comprehensive and very nice presentation. Any question from the floor?
So Haslani, Chingy here. Hello.
Hi.
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 I just want to ask, right? You told that acute liver failure or either chronic liver failure, because you did mention that morphine will be if you use morphine, then the effect will be longer. But remifentanil is the best choice. How about fentanyl?
Fentanyl is also metabolized in the liver, but it's cause less liver toxicity. It still can be used in liver patient.
If among all the sedations, usually those that ventilate will usually use mitamorphine. So your recommendations for those acute liver failure or chronic liver failure, the sedation you suggest fentanyl and midazolam or any other combinations that you suggest?
I think fentanyl will be the better choice for liver patient compared to morphine. Or any other answer?
Let's ask Prof. Gan.
No answer. There is a suggestion to use Presidex. Yeah, it seems to be a drug that more people are using. We have not started using it. It's available, but we can get it from adult ICU or anesthesia. There's some suggestion to use it. So the other day I was talking to Haslani. Perhaps we can discuss about these and come out with a guideline how to use it, because one of the side effects of this is if people are not aware of this, go and purge like usual sedation, it may cause a hypotension that cause more, you know, harm to the child. So this is a drug that apparently many liver transplant centers are moving to using.
Okay, thanks, Prof. Kat. Yeah. Any other question? Myra, you want to ask?
Hi. Yeah. Hi, Hasliani. Thank you for the presentation. My question is that what are the choices for your muscle paralysis during the intubation for this acute liver failure or chronic liver failure that going for that decompensated and needed intubation in PICU? Because what I know is rocuronium is being metabolized in the liver. So, I mean, what from your reading, is there any recommendation in regards of the choice of muscle paralysis for this kind of group of patient? Thank you.
Okay. So I have come across the neuromuscular blockage in the liver patients, but they didn't really specify the choice of the which one is better, because all metabolites in the liver, but it's not causing hepatotoxicity, most of the drugs. So there wasn't any specific that they recommend to use it as a neuromuscular blockage.
Hasliani, sorry, Chingy here again.
Yeah.
Because this one, since talking about, I mean, the muscle relaxants, I think one of the drugs that, but very short acting, the atraconium and cistraconium, but in the intubations, it'd be a bit too short, right? To use that drug as an induction. What you think? Because the atraconium and cistraconium actually is quite safe to use in the acute liver failure or chronic liver failure. But what do you think about regarding that drugs, the short-acting muscle relaxants in the initial induction phase for our intubation for those that are acute and chronic liver failure?
I think because all those are very short, it's like rocuronium is 1 minute, and all short acting. I think there's no major problem in the liver patient so far as I know, including the liver disease patient using this muscle relaxant for the induction for the intubation.
Correct me if I'm wrong, but atracurium is Hoffman degradation, right? So it bypasses the liver.
I think the approach here, my humble opinion, I think the approach of NS and our side as a pediatric intensivist is a little bit different, because NS, when they induce the patient, they want to have a reversible myorelaxation at the end of the operation. So they are aiming something that can be excreted or metabolized from the body fast enough so that they can extubate. But for us, I think if you want to induce just for the method of intubation and you are going to keep the child ventilated for a few days, I think the induction period, what drugs of choice shouldn't be a big issue. But if you want to have the child to have a short procedure and then wake up, as like how Chong had mentioned, I also learned from my pediatric NS here, the atracurium or cis-atracurium is much better because it is not an organ dependent myorelaxant. Not organ dependent means that they don't need liver to metabolize and no need kidney to excrete. They are degraded by Hoffman degradations and plasma esterase cleavage. So in that sense, even the liver is insufficient, you are quite safe that the wear off effect is quite okay. But in terms of intubation for the sake of keeping the child ventilated, I think my approach, I think I won't be so jittery of whether I want to use rocuronium or atracurium. Maybe you should ask our consultant.
Avani, you're saying something?
Oh, no, sorry, I probably didn't introduce myself just now as well. Yeah, so it's just atracurium is perfectly fine because as Hugh has mentioned, it's hormone degradation, so it bypasses the liver and renal. But having said that, I mean, from my limited experience at Westmead, we do get quite a few liver transplants, and I agree with Prof. Gan that we're actually moving towards Prisex infusion, but we do not use morphine. We still do use morphine, but yes, we're moving towards Presidex infusion to manage these post-liver transplant patients. But in terms of acute liver failure that present, a lot of times they're probably encephalopathic as well. So we do find that we don't really need to use much drugs to actually proceed as pre-meds to actually intubate them.
So which agent that you use, Avani?
We still use rocuronium because it's just a one-off dose and then it will just come off. Yeah.
Hi, Tavani. Just wonder, regarding the Presidex infusion, how long, because from what I've read, I counted before this, they did not really recommend prolonged usage of Presidex. But in your previous experience, how long does they use the Presidex for the infusion, and whether there's any side effect from the Presidex itself?
Because we usually have a very short term of ventilation of our post-liver transplant patients. So a lot of times we only use it for 48 hours. We don't usually have the need to use more than 72 hours. Most of them are either extubated within 24 hours, if not less.
Excellent. Yeah. Carry on.
Chang here. So I want to ask, right? I also not familiar with PCTEX. The PCTEX, the infusion, is it follow the Fanshan? Sorry, the dose for the PCTEX infusion. Is it follow our Fanshan or any specific guideline from follow which sorry, thanks.
No, I think you can use Fangshan. What we use here at Sedang is 250, but essentially it's just the volume that you are prepared to use and the size of your patient. So if you're conserving, then you probably dilute less. But yeah, I mean, unless if anyone else has any other option, but it's usually 200 mics and 20 was what I used in Westmead. Here in Sedang, we use 250. 200 mics and 50 minutes.
Means that once we prepare, the dilution will last for 24 hours or have to change means, for example, just now we mentioned about 48 to 72 hours, but we aim for towards extubation for all the liver transplant, post-liver transplant. So those that once we prepare, it lasts for 24 hours or actually can actually last until the string finish.
I'm not sure about that. But I think most drugs are 24 hours, but sorry, I don't have the answer for that.
Okay, thanks, Tony.
I think just I'll talk about rocuronium or atracurium. I mean, there's no issue of using atracurium, because atracurium, actually in the past we have been using atracurium. The onset is just a bit slower. I think particularly for liver patient, is cannot be metabolized in liver. But I agree with all, it's just one dose, it's not a problem. But I do see patients after rocuronium, I think the effect doesn't seem to be good. Yeah, so with atracurium, for liver patient, something for me to go and find out more. Yeah, but the Presidex is usually used is just very short. I think post liver transplant 24, 48 hours, it should be activated already. So it's meant for short-term use. And the dose should be just same like the usual dose, shouldn't be any different. And the recommendation usually is titration, not to use a big dose. Titration is the way to go.
Yeah. Any other question? So Hasilani, hepatorenal syndrome.
Yeah.
Yeah. So yeah. So is there any renal insult in hepatorenal syndrome?
Because renal insult, it will lead to AKI also, Dr. Cho.
Okay.
Because of the
Yeah, I mean, yeah. So you define AKI, but then would the question is that in hepatorenal syndrome, is there any cellular damage in the kidney?
not sure. I'm not sure.
Right. So yeah. Q&A. Hepatorenal syndrome. Is there any damaged renal cell?
Shouldn't have it's a function impaired rather than structural damage.
Okay, yeah. So it's a functional impairment. So as you very nicely demonstrated, yeah. So it is vasodilation. Yeah. The peripheral vasodilatations that lead to relatively hypotension or hypoperfusion. Yeah, so relative hypoperfusion that leading to renal vasoconstriction. Yeah, so that lead to impact in the renal function. So that's why the treatment of the hepatorenal syndrome will be fluid resuscitation. Yeah, so you give some albumin first and then fluid resusc first, and then try not to give any furosemide. Yeah, because our usually reflex is that when a liver failure, then no urine output. So our major concern is, oh, this child might be the kidney might not function. So our usual mechanism is give Lasix. So, but in this situation, it's a bit different. So hepatorenal syndrome, we know that the peripheral vasodilated. So the treatment is to replenish the fluid rather than giving Lasix. Yeah. No doubt when times go by, if we didn't treat this hepatorenal syndrome, then subsequently, then we're going to have renal ischemia, yeah, and also renal damage, yeah, the cellular damage of the kidney, yeah. So that's a very important clinical application in so-called the hepatorenal syndrome. So in fact, there are two types of hepatorenal syndrome. So one is so-called a functional one. The other one is already with the cellular damage. Yeah. Good. Yeah. Okay. Any other question? Okay. Jin, you want to share your experience of managing liver patient in Taiwan? Taiwan team also have a lot of liver transplant patients, like and the liver cases in Taiwan.
Yes, Dr. Chaw. There is quite a number, but I think the practice almost similar to Malaysia, what we practice.
Okay.
I think not. I see that not much of obvious difference, Dr. Chaw.
Oh,
also, I aim towards the extubation 48 hours to 72 hours. Almost similar, not much of obvious difference.
Okay. Do they use a lot of CRRT and TPE over that side? Or they have
they usually, while waiting for that, they usually use they will dialyze what we call liver dialysis. before prepare for the child. If let's say the child came in with acute liver failure, those that already end stage liver failure, then that one is like what we usually do. But I never see the mask are the ones that what we call the mask. I never see in Taiwan. A lot of time it those that acute, they want to buying time to bring down the ammonia to do some liver dialysis using their HD like the normal CRT machine. In terms of liver transplant, almost similar, no obvious difference in terms of no obvious.
Okay. All right. Thanks. So the other thing is anatomy question, like Danny. Yeah. Anatomy question. So that like for neonate, because sometimes it's quite interesting to know that especially neonate that when they put in a UVC, yeah, when you put in a UVC, do you remember the anatomy of the UVC and related to the portal vein and also the hepatic vein?
It can cause portal vein thrombosis, right?
Yeah. So do you remember how it does it cause? And then in terms of anatomy variant and normal anatomy variant. Yeah. I just asked my MO this morning. Is he going to find out the answer for me? Yeah, because we will just have a neonate in the unit with UVC and USD. Yeah. So, do you remember the anatomy relationship? Which might be quite important for us because sometimes we do have receive patient. And we know that the UVC is associated with NEC. Yeah.
It's related with the position of the tip of the UVC. Where is the where the blood supply derived from? But I'm not very sure which level already.
Okay. Yeah. So I mean they are
related to the.
So it's so you just remember the UVC will first go to the the left branch of the portal vein. You remember the portal vein? The portal vein goes to the liver, then subsequently it branch out to two. Yeah? So first you go to the left branch of the portal vein. Huh? And then after that, from there, you still remember there is a ductus venosus.
Yeah.
Okay. So the ductus venosus actually connecting the portal vein to the hepatic vein. Right? Yeah. So they follow through. The normal follow through. So from the UVC connected to the left portal vein. Then from the left portal vein, there's a ductus venosus that connected to the hepatic vein. Yeah. Then from the hepatic vein, then you follow the hepatic vein, go to the IVC. Right. So sometimes if our UVC deviated to the left side, most of the time you pusing ke kanan, deviated to the right side. When you deviated to the right side, it will impact the flow of the portal vein. Yeah. So when you impact the flow of the portal vein, sometimes cause stasis, or slightly portal vein increase in venous pressure. So this increased venous pressure sometimes will cause problem to the gut. Yeah. Okay. So that is in terms of important anatomy. Any other questions? So in the liver impairment, so you're mentioning that the AST and ALT will be the liver enzyme that you're looking at. Yeah. So in which one is more important, ALT or AST?
ALT. Alanine.
Yeah.
Because AST also be produced by other organ. It's not liver specific.
Yeah, good. Yeah, so this thing is very important. So the ALT is very important. So with the high AST also produce myocardial muscle. Okay. So like a myocardial infarct. So you're going to have a high AST. Yeah. Good. Okay. Any other questions from the floor? Okay. You're aware that this conversation is being video and recorded, and we're going to be published in the YouTube channel. Okay, I hope you don't mind. Yeah, yeah. So that the best, so that I can refer back your presentation. Yeah. Okay. Right. So yeah. Okay. Yeah. I think it is no more than we will end this session. Hi, Michelle. You baru masuk, Michelle. We miss you.
Baru habis tengok post-op patient, sorry.
No worry. We miss you. we just finished the session. Yeah.
Okay. Nanti Hasliani give me private tuition.
Yeah. No. Hasiani, you say that. Please go to my YouTube channel.
Oh yes. Okay. YouTube channel.
Yeah. Let's go to the YouTube
See you
channel.
all.
Okay.
Bye.
Okay. So I'll see you next week. Next week, who will be presenting?
Next week. Yeah, check first.
I think Chi will be presenting next week.
Okay. So it's early already. Yeah. Okay. Don't worry. Yeah. So I'll see you all next week. And, I think this evening there is a session on the ultrasound, hemodynamic ultrasound, echo. After I send you the link if you have not yet registered. I'm not sure. I think it's today. Okay. I'll send you the link later. Okay. Right. Bye everyone. Thanks.
Thank you, Robert. Thank you. Thank you, everyone.
Thanks, Sally.
you.